Good morning, everyone. We're just going to give everyone another minute to continue joining, but thank you all for being here. All right. Okay, I think we'll go ahead and get started. And my screen should be sharing, so hopefully everyone can see that. But hi, everyone. My name is Lindsay Von Dyke, and I am a program specialist within the Behavioral Health Benefits Coverage Unit with Nevada Medicaid. I am over outpatient and rehabilitative treatment services. Thank you all for attending today's public workshop. I'll be starting us off with my presentation on First Episode Psychosis, and then we'll switch over to Chris Ann Taylor's presentation on Assertive Community Treatment, and I will close us out with the presentation on peer support services. As a reminder, this workshop is being recorded and the slide decks and policy drafts are posted on Medicaid's Public Notices webpage. And before I jump in, I do want to start off by saying a big thank you to all the providers and stakeholders we've been working closely with on these policies. I'm very grateful for all of your feedback and collaboration, so I appreciate you all being on this journey with us. During this presentation, I will review the revisions made to Medicaid Services Manual, MSM Chapter 400, Section 403.4 D3. This section covers coordinated specialty care for the treatment of first episode psychosis, and then there will be time for public comment at the end of my presentation. All right, so I'm going to go ahead and pull up the policy. So I'm going to stop sharing my screen and switch over. Just give me 1 second. All right, so the policy should be up on the screen now. So displayed on the screen is section 403.4 D3, coordinated specialty care. Before jumping in, I do want to say, oops, sorry, I heard an echo, sorry about that. There are ongoing discussions with CMS regarding the SPA for FEP, so there may be a few additional revisions made beyond what is presented today. And now I'll go ahead and walk through the current revisions made to this section, and there will be some scrolling, so I apologize for that in advance. Beginning with the definition of first episode psychosis, we have added language to differentiate between affective psychosis, which typically occurs between ages 12 and 25, and non-affective psychosis, which typically occurs between ages 15 and 35. Language was added to state that the treatment for both groups should be based on the individual's need and should be medically and clinically appropriate as determined by the coordinated specialty care team. And then moving down, Section 403.4 D3A, the program functions and treatment fidelity section was added. Number 1, general program functions, and number 2, program certification were included in the original policy. They have just been moved under this new section and the order was switched. A sentence was added in the general program functions to discuss the assistance provided to recipients to help them regain and restore skills needed to be successful with employment and education. This was added due to the removal of supportive employment and education as a service, which will be discussed shortly. Moving down. Number 3, team meetings, and number 4, treatment plan meetings were added to include definitions of both types of meetings that are performed under this service model. Team meetings occur without the recipient present, and treatment planning meetings occur with the recipient present. The frequency of these meetings will be determined by the team leader. Sorry. And then moving down, the final 3 topics in this section include continuous fidelity monitoring, small caseloads, and retention in the program. These sections were added due to feedback we received, and we wanted to include them here to show what they look like in policy. We greatly appreciate this feedback and believe these items are important to the CSC model. However, after internal discussion, we believe these 3 topics should not be included in Medicaid policy, as these will not be aspects of the model that Medicaid will monitor. We believe these are better left monitored by the certifying body. So following my presentation, we would appreciate feedback on whether or not stakeholders agree with removing numbers 5 through 7 from Medicaid's policy. And then moving to section 403.4 D3B, eligible providers. Here we have added language that states the group must obtain a unique and separate NPI for the delivery of coordinated specialty care services. And I'm going to scroll a little bit more. Okay, a psychiatric prescriber has been added to the list of eligible members. This provider can be a board-certified psychiatrist, an advanced practice registered nurse with psychiatry specialty certification, or a licensed physician assistant with psychiatry specialty certification. They are responsible for medical and psychiatric evaluations, pharmacological treatment, and primary care coordination. In the qualified mental health professional section, we have added language to state that they must be supervised by a licensed professional. Moving to the next page. The case manager and supportive employment education specialist providers have been removed per CMS guidance. Section 403.4 D3C, eligible members. The age range was expanded to 12 to 45 and the time frame of experiencing FEP within the last 18 months was removed. And scrolling down. 403.4 D3D, covered services. Supportive employment and education has been removed as a covered service. This is due to CMS guidance, as Nevada Medicaid does not have the authority to pay for this service. We have replaced SEE with psychosocial supports. Per CMS, we have removed case management and primary care coordination, and the service of care coordination now encompasses both of these services. Psychiatry was removed from the list of covered services, and we will also be removing crisis services from the list following recent CMS guidance. Both of these services will be allowed to be billed as a separate service outside of the FEP bundled rate. Scrolling down. The family education and support definition was revised for clarity and readability, and both the SEE and primary care coordination definitions were removed. Moving down to non-covered services. So in this section, room and board expenditures and caregiver services were removed from the list as these services were not relevant to the FEP model, and team meetings without the recipient present was added to the list. And then finally, section 403.4 D3E, authorization requirements. The service limitation for the screening and introduction code was revised to allow for 4 units per calendar year before a prior authorization is required. This was updated in the billing grid below as well. We have also made a note that this bundled rate cannot be billed on the same day as another behavioral health bundled rate. And this concludes the revisions made to the coordinated specialty care section. So I'll go ahead and switch back to my presentation. So I'm going to stop sharing and then switch us back. Just one second. All right. So this concludes my presentation on FEP. So I will now open up for public comment. Do we have any questions or comments at this time? And I see Leah Cartwright's hand. You can go ahead.
Good morning. Thank you. Leah Cartwright here today on behalf of the Nevada Psychiatric Association. I just wanted to say a big thank you to you, Lindsay, and the rest of the Medicaid team for taking the comments and concerns of the psychiatric community into consideration when you created this. I will send them the information on sections, those numbers 5 through 7, on if continuous fidelity monitoring small caseloads in the retention section should be removed and put that under the purview of just the programs operating this. I think it's fantastic that you included the ages for early stage affective psychosis and included that psychiatry can be billed separately instead of the bundled services. That's very helpful for ensuring the fidelity of these programs. So thank you so much.
Thank you, Leah. I appreciate that. And yes, we will gladly take that feedback on the numbers 5 through 7. So I'll look forward to seeing that. But thank you for that. I appreciate it. And do we have any other comments or questions at this time?
Hi, I had a few questions regarding some of the things. So for the qualification, it says evidence-based, nationally recognized, model approved. So that does not specify it has to be a Navigate model.
Yes, that's correct.
Okay. And then when it comes to retention, of the
Dr. Daniel.
Clients shall not be discontinued even under circumstances involving lengthy interruptions of care. Could you give me a little bit more information about that? So if we have a 2-year program and a client goes away or refuses services, you're saying that they cannot be discontinued
Thank
unless
you
it's a
for,
lengthy interruption?
yes, thank you for raising that. This is something that I hold from other regulations that I found, but it may not be appropriate in this policy. And like I mentioned, this is a section that we're considering removing, as I mentioned, Medicaid wouldn't be monitoring the specific, like the retention in the program. And it's, if you are raising concerns about it, I think that's more of a reason to potentially remove this, because like I mentioned, this isn't something Medicaid would be continuously monitoring. So if it doesn't feel like that's appropriate for the model, that's good feedback and helpful for us to know.
I appreciate that. Thank you.
Thank you. Yes.
And then the ages as well, because typically we do 15 to 44, but you're saying now that the FEP program must start opening up to, I think it was at 12? I'm trying to remember.
Yes, we did expand the age range from 12 to 45. I think the purpose in that is just broadening the services to ensure that we're not excluding potential members from the service. So if your program starts at 15, I think that would still be appropriate. It would just be dependent on who qualifies for the service. I think the goal in expanding the number is just ensuring that we're not limiting services or potentially leaving out people that could qualify for this.
Okay. And then I see that there originally was within the last 18 months. Um, I do believe there needs to be language about first episode versus chronic condition. So without having any type of time frame, generally we have an onset of 5 years after that point, or 12 months of antipsychotic medication use. We do have eligibility criteria that I don't necessarily see in here. Unless I'm speaking out of line, my supervisors would need to give their feedback as well, but it seems a little light. Seems that basically if you're 12 to 45, whatever, no matter how much treatment you've had, you can access first episode, and that doesn't necessarily fall in line with first episode services. But if I said something incorrect, please somebody let me know.
No, thank you for that feedback. I appreciate that. I think similar to expanding the age range, also with removing that, again, we just are hoping to not limit services. But this is good feedback that I can definitely bring back to the team and we can discuss further if maybe we do need to have that time frame in there. And it also, it sounds like you mentioned a 5-year time frame, so maybe something more similar to that, but more appropriate for the model. And it's something I can look into a little bit further too.
Yeah, if we want really first episode versus somebody that's, if somebody comes to us at 40 and they've been treated for the last 20 years, by definition, they're not first episode. It would be outside the purview of this particular program. So that's my concern. It really does need to be narrowed down to the first episode population versus just mental health treatment of anybody with a psychotic disorder. So thank you.
Thank you. Yes, I appreciate that feedback. And I know part of this too, we do like to lean more on the clinical determination of who's enrolling them in the FEP program. So more, we leave that up to the clinicians to make that like the team leader, whoever is doing the assessment. So I know that's also a place Medicaid tries to step out of the clinical role a little bit more, but like I said, I will take this back and we can discuss internally if we do need to maybe have a limit in there, if that would be more appropriate. So thank you.
Thank you.
Do we have any other questions or comments? Not seeing anything right now, so I'll go ahead and move over to my contact information. So if anything else does come up, please feel free to reach out to the behavioral health inbox and we'd be happy to help answer any questions that you have. And this does conclude my FEP presentation, so I'm going to go ahead and pass it over to Chris-Ann Taylor, who's going to be talking about ACT. So I'll stop sharing.
Thanks, Lindsay. Let me just get my presentation up. All right. Can you see it okay? Perfect. All right. So good morning, everyone. My name is Chris-Ann Taylor, and I'm a social service program specialist with Nevada Medicaid. Today, we're going to review revisions to Nevada Medicaid's policy for assertive community treatment. As Lindsay mentioned, today's meeting is being recorded, and copies of all the policy documents and presentations will be available on our public notice webpage. So here's our game plan for today's workshop. First, I'll provide a brief overview of assertive community treatment. Next, I'll walk you through the proposed revisions to ACT services within the Medicaid Services Manual. And finally, we'll open the floor for public comment and questions. Before I begin, I'd like to extend a sincere thank you to all of our stakeholders for their continued collaboration. Your insights have been instrumental in shaping Nevada Medicaid's ACT program, and we deeply value your ongoing support and engagement. So what is ACT? Assertive Community Treatment, or ACT, is a team-based, person-centered mental health service model for individuals with serious mental illness. ACT provides intensive, community-based support through a multidisciplinary team who delivers care directly where the participants live and work. Some key features include low staff-to-client ratio, 24/7 crisis support, and assertive care, which refers to the proactive and persistent approach the ACT team takes in reaching out to individuals, ensuring they receive the care and support they need, rather than waiting for them to seek help. It means meeting people where they are, both literally and figuratively, with most services offered outside of a traditional clinical setting. ACT aims to reduce hospitalizations and improve quality of life through consistent, individualized support. ACT is designed for individuals with serious mental illnesses who also experience significant functional impairments. These may include frequent use of emergency services, involvement with the criminal justice system, housing or employment instability, difficulty living independently, or limited success with traditional treatment approaches. Now let's review the proposed ACT revisions within the Medicaid Services Manual, beginning with section 403.6D. So give me just a moment as I pull that up. Oh, stop sharing. Share. Can you see that all right? Perfect. All right. So throughout the ACT policy, language was strengthened and refined to enhance clarity and ensure consistency with the rest of the chapter. 403.6D, the definition, we incorporated language that emphasizes the rehabilitative support offered to participants, which is aimed at fostering their independence within the community. This includes the development of skills necessary for success in employment and educational settings. These additions were made in response to the removal of the supportive employment and education specialists from the team structure. 403.6D1, eligible providers. This section has been expanded to clarify that all ACT teams are required to obtain a unique and separate National Provider Number, or NPI, for the delivery of ACT services. We also included language specifying that certified community behavioral health clinics, or CCBHCs, who, upon receiving ACT certification, may utilize the ACT daily rate in place of their CCBHC PPS rate when providing ACT services to ACT participants. 403.6D1A3, ACT teams. Throughout this section, all references, oops, it's not showing it right. Give me just a minute. You can't, there we go. So throughout this section, all references to full-time employees have been removed to allow for greater flexibility in staffing, particularly to better accommodate the unique needs of rural and frontier areas. (403.6D1A5A), the team leader. So the definition of the team leader has been expanded for greater clarity. Additionally, it is now specified that if the team leader is not qualified in co-occurring disorders, then at least one other team member must be a certified or licensed substance use disorder treatment specialist. Where's my psychiatric prescriber? There he is. Okay. So here, 403.6D1A5A, the psychiatric prescriber, here we added clarification of the qualifications required for individuals serving as the team's psychiatric prescriber. And just like in the first episode psychosis policy, the supportive employment and education specialist, as well as the case manager, both of these roles were removed at the direction of CMS. In place of the supportive employment and education specialist, we have incorporated psychosocial supports and given ACT's team-based approach, case coordination, to case coordination, a dedicated case manager role is no longer appropriate. 403.6D, 1A, 6C, both of these roles, the licensed professionals and QMHPs, were added as allowable team members to support flexibility and meet the high service needs of ACT participants. (403.6D1B1) operational requirements, we added language to reinforce high fidelity implementation, the use of evidence-based models, and compliance with DPBH certification standards. The team meeting section was also revised to provide greater flexibility for smaller teams. Then 403.6D1B3, individual treatment plan. So a small section was added to clarify that all ACT services must be documented in each participant's individual treatment plan, or ITP. Additionally, examples were provided to illustrate how team members proactively engage and support participants in their recovery and community integration. Under covered services, 403.6D3, and in alignment with CMS guidance, we removed references to supportive employment and education, replacing it with psychosocial support. Additionally, case management has been replaced with case coordination to reflect ACT's team-based approach and to maintain compliance with CMS requirements. Finally, 403.6D6, billing. Within the billing chart, we clarified that the ACT daily rate cannot be billed on the same day as other outpatient behavioral health bundled rates, and language was added to explain that providers utilizing the ACT daily rate may not bill separately for services included in the bundled rate. However, they may bill separately for services delivered outside of the bundled rate. So this concludes the revisions to the ACT policy. Give me just a moment as I go back to my presentation. Oh, I've lost my volume. Tell them I just lost my volume. Goodness. Can you hear me now? Okay, sorry, I lost my audio. ACT teams will enroll under provider type 14, specialty group 814, as well as the new specialty number 318 for our ACT teams. Providers will automatically be linked to both of these specialties. Thank you for your time. This concludes my presentation. I'll now open it for public comment or questions. Yes, Helen, go ahead.
Good morning. This is Helen Bird from the Division of Public and Behavioral Health. Chrisanne, I just had a question on the crisis stuff. Will the crisis, if there's crisis services provided, would that be included in the ACT rate, or would that be billed as a separate rate?
Crisis intervention. Crisis intervention would be included.
Okay, thank you.
Right. Mm-hmm. Anyone else? If not, you can always reach out. Here's my contact information. So don't hesitate. And I'll hand it back to Lindsay to finish this out for today.
Thank you, Chrisanne.
Mm-hmm.
All right, I'll go ahead and share my screen again. Okay, So once again, my name is Lindsay Von Dyke, and I will now be presenting on peer support services. And this is the final presentation of this workshop. And I also want to say another quick thank you to the peer providers who have offered amazing support and collaboration on this policy as well. During this presentation, I'll go through the revisions made to MSM Chapter 4300, Peer Support Services. The revisions include the addition of a section to describe plan of care documentation and updates to the service limitations. There'll be time for public comment at the end of my presentation. For all three peer support services, adult, family, and youth, we have added a section to include a description of the plan of care documentation, which is required for these services. On the screen is the language pulled directly from policy. There are a few revisions being made to this description in the family peer support section, which will be incorporated prior to the public hearing. But to provide a brief overview of the current revisions, plan of care is a comprehensive individualized plan that outlines treatment goals for the recipient and a plan for achieving those goals. The plan of care will be developed by the peer support specialist in collaboration with their supervisor. If the recipient has a therapeutic team, then the peer team shall incorporate the same goals from the therapeutic treatment plan. If the recipient is not receiving therapeutic services, then the treatment goals shall be developed by the peer team. The peer team must monitor and update the plan of care at least annually, and it must be signed by the peer support specialist, their supervisor, and the recipient. The plan of care should include service plans with needs, outcomes, and strategies that are specific, measurable, and achievable. We have also revised the service limitations for adult, family, and youth peer support services. For all services, the limitations are currently 72 hours or 18 units annually, and we propose to update these to 52 hours or 208 units annually before a prior authorization is required. And this concludes my presentation, and this is the final topic for today's workshop, so we have the remaining time for public comment. Do we have any questions or comments at this time? Stephanie?
Yeah, Stephanie Cook with the Division of Public and Behavioral Health. A quick question, is this, and maybe I missed it, is what provider type is this referring to as we look at these peer services?
This is for provider type 97.
Okay.
Yeah.
So none of the information you just provided on like the prior auths will be applied to like a different provider type that has peer services. Will they be aligned, or will it be different for provider type 97?
So these service limitations will be for all peer providers. So even if a peer is linked to, say, a 93 group, these service limitations will still apply.
Cool, thank you.
Of course, thank you. And then I see next hand, Sherilyn.
Yeah, Sherilyn Arwood for the record. Quick question, peer support team, who is on that team? Just to clarify that. And then secondly, you spoke to youth. What are the ages of the peer supports that are going to be working with the youth teams or the youth clients?
Thank you for those questions. So the peer team, so in the provider type 97, you can enroll as a peer individually, and then you'll just be required to link to a group. But we also have a peer agency or group specialty as well. And for that peer specialty group, it's required that they have a peer support supervisor, and then the individual peers will enroll or link to that group as well. So the group structure, they'll just need a supervisor in order to enroll as a group peer agency. And then for your second question, I believe you talked about youth and the age range for the providers. I would have to double check on that because I believe I'm not remembering the age range. I believe it was 18 to 30 that we put in for youth peer support, if I'm not mistaken. Okay, Sarah's nodding, so yes. In order to be a youth peer support provider, the age range is 18 to 30.
Okay, thank you so much for clarifying that.
Yes, thank you. Oh, any other questions at this time? Kyle, sorry.
Just to clarify, if all of our peers are under provider type 93, this would still apply and we're still okay with that. They don't have to be in the 97.
Yes, that's correct. Any claims
Okay.
submitted for peer services will have these new service limitations.
Okay. And the second question is like how our EHR is built. We can only really do one treatment plan at a time. would it be something that we could, if the therapists and the peer support are working together, that that plan of care would be on the therapist treatment plan? I'm just trying to see how that works, because that's what we've had kind of struggles with, is multiple treatment plans with multiple different disciplines.
So that's a great question. So I think the goal here, because peers are not clinical, they would have to use the plan of care, which is that separate document. So the idea would be, if the therapist does have that treatment plan documentation, the plan of care would be a separate document that would just mirror what the treatment plan is, but it'd be more specific to the peer services, and it allows the non-clinical peers to be able to write that documentation. So they would closely align and complement each other, but it would have to be a separate document for just the peer services.
Okay, thank you.
Yes, thank you.
When does this go into effect?
So this is just the public workshop today. So we're aiming to go to the February public hearing, and once it's read into hearing, then it would go into effect. So we're aiming for February's public hearing. So then the effective date would hopefully be March 1st of 2026. So that's the goal, but more announcements will come out about the hearing and when that's going to be presented.
So this is a proposal, or is this going to be the actual?
So it is just a proposal right now, and then we're taking feedback. If there are, like I mentioned, there's some minor changes we're making to the family peer section in the plan of care language. So we're taking feedback that we're able to incorporate prior to the hearing, but these are what we would like to bring to hearing. If that makes sense.
Okay, thank you.
Thank you.
And then real quick, just to add to that, Esther, PT 97, which is the new provider type for peer services, is already built and live. This is just an update to our new peer policy, which is MSM 4300. So peers can get enrolled now, whether they're adult peer recovery support specialists, family peer supports, or youth peer supports.
Thank you, Sarah. Right. Do we have any other questions or comments at this time? Okay, I'm not seeing any. So I'll go ahead and again, pull up my contact information. So if anything else does come up, please feel free to reach out to the behavioral health inbox. But thank you all for attending today's public workshop.
Thank you.
Thank you.
Thank you. Have a good day, everyone.
Thank you so much. Thank you.